Greetings, my name is Dr. Robert Gish. I'm here to present this virology meeting, Hepatitis B Cure, on Delta hepatitis, new and potential antiviral targets. My disclosures are on this slide. We're going to today review the overview of the hepatitis delta life cycle. We're going to highlight preclinical and clinical targets for antiviral development that are currently in progress. We're going to also look at very recent data on results of agents in clinical development. Delta virus is always a co-infection with hepatitis B, although there's been some recent research that hepatitis delta can also coexist, co-replicate with RNA viruses. In this setting, delta requires surface antigen to complete virus assembly. This is an RNA virus that makes a small and large delta antigen and has a prenylation group. There are over 15 million individuals worldwide and between 70,000 and 150,000 in the United States. There's no FDA-approved therapy. Delta virus is the most severe form of viral hepatitis. Approximately 50% of hepatitis delta infected patients have cirrhosis at diagnosis. This is very important to know in terms of urgency of drug development and also the patient populations that need to be studied. There's a higher risk, of course, of liver cancer, death, liver transplant, and end-stage liver disease. There are multiple potential preclinical targets for delta hepatitis. We'll talk about the clinical ones in just a moment, but look at this wonderful diagram. Important is used for nuclear import and export. RNA transcription takes place with a number of different host enzymes. Prenylation, a host enzyme system for packaging, also is present, as well as a number of other enzymatic steps. Packaging and export also takes place, and the delta antigen has over 100 interaction factors. Intracellular transport has also been identified. First, let's talk about delta entry. Delta, like hepatitis B, uses the NTCP receptor for cellular uptake. Prenylation, a cell-based liver enzyme, is required for HBV assembly as prenylation takes place of the large delta antigen using the farnesyl transferase. Let's now talk about therapies in advanced clinical development. This diagram highlights Bulevirtide, an entry inhibitor, prenylation inhibitors, specifically Lonafarnib, nucleic acid polymers for inhibiting packaging and release, an immune modulator, Pegylated interferon lambda, that attaches to the lambda interferon receptor and stimulates downstream JAK, STAT, and interferon induction pathways. Let's now talk about an entry inhibitor. Merclid-XB, now called Bulevirtide, is a subcutaneous medication that's approved for the treatment of compensated delta in adults in Russia since 2019 and in Europe under the name Hepcludex since July 30th, 2020. This is a lipoprotein modified pre-S substance that targets the NTCP receptor. This blocks the receptor function and hepatitis B and delta virus entry. This requires daily subcutaneous injections for 48 weeks after reconstituting lyophilized powder. 48 weeks of a higher dose, 10 milligrams of Bulevirtide, as monotherapy with PEG interferon alpha-2A, patients co-infected was looked at in the MER 203 study, specifically the extension study, which we're going to be looking at today. Key inclusion criteria are highlighted here. Primary endpoint of undetectable HBV RNA at week 72, off therapy 24 weeks, was identified. Secondary endpoints include undetectable delta RNA serum at week 48, ALT normalization, and S antigen decline. Here in the upper graphs, we're showing the representation of the median delta RNA reduction. In green is the Bulevirtide plus PEG interferon, the gray line PEG interferon monotherapy. In the right graph, you're looking at viral decline on combination therapy in blue, Bulevirtide 2 milligrams, and the dark green. Let's look at the primary endpoint. This was interesting in the pegylated interferon study that the higher dose, there was a lower primary endpoint reached at 6.7% of undetectable HBV RNA. Conversely, using Bulevirtide plus tenofovir, we had a 33% of patients reaching that primary endpoint. So clearly with these dose changes or dose differences in terms of viral reduction, there may be a different dose chosen for the TDF or combination with the nucleoside or nucleotide analog versus combination with pegylated interferon. As you note, the 2 milligram plus pegylated interferon reached 53% at the primary endpoint. Let's now talk about a host enzyme system, farnesyltransferase, which results in prenylation of the large delta antigen. Lonafarnib, first and only oral agent in development for delta hepatitis, has been well characterized in previous studies. Most common adverse events are GI related. It's a class effect and have been well identified. It's an orphan designation and breakthrough therapy designation. Orphan in the US and EU, and the FDA breakthrough EME prime designation. Let's look at the phase 2 data. This is 2 Lonafarnib-based regimens identified for registration. So we have Lonafarnib plus ritonavir boosting. This decreases the amount of exposure to Lonafarnib and lessens adverse events. And Lonafarnib BID boosted plus pegylated interferon alpha 2A. The composite endpoint was reached in 29% of individuals on the Lonafarnib and 63% when Lonafarnib was combined with pegylated interferon. This composite endpoint is a 2-log decline in delta RNA and ALT normalization. This is the lower 2 study. A study that's ongoing, global study currently today is a phase 3, and the study design is highlighted here. We're looking at Lonafarnib plus pegylated interferon versus monotherapy of pegylated interferon and placebo. Lonafarnib will be ritonavir boosted. The endpoints will be a comparison of the Lonafarnib 2 arms with placebo. Pegylated interferon is there for comparison, contribution of effect only. Primary endpoint again, 2-log decline at the end of treatment plus ALT normalization. The secondary endpoint of histologic improvement. We will await, excited about these new results. Let's now talk about immune modulation. This is with pegylated interferon lambda, which attaches to a different receptor than standard alpha-2A and alpha-2B, but stimulates the JAK-STAT pathway, interferon signaling gene induction, and antiviral activity. Lambda interferon is a well-tolerated type 3 interferon that binds to a unique receptor highly expressed on hepatocytes. Over 3,000 patients have been looked at in 19 different clinical trials and has an orphan designation in the US and EU and an FDA breakthrough therapy designation. The LIMIT mono phase 2 study looking at lambda interferon 120 versus 180 micrograms Q week for 48 weeks with a 24-week follow-up has been presented. There are subcutaneous injections, as you know. Inclusion criteria were standard with compensated liver disease. Tenofovir or entecavir was started at the baseline. In this phase 2, we had a 36% DVR. So interesting terminology, durable virologic response or maintained virologic response. We're not using the word SVR because that's been applied to hepatitis C, which is curable. We're not sure that delta is curable. And as long as the hepatocytes are making S antigen, there may be tiny remnants of delta infection present. This is an impressive result with 5 out of 14 being below level of quantification at 72 weeks. Regression of liver fibrosis following 48 weeks of lambda and delta is highlighted here. These are 2 case studies with pre-treatment biopsy F5, moving to an F1, case 2, F4 with bridging fibrosis, moving to mild portal fibrosis F1 after 48 weeks of lambda interferon treatment. This was presented at the FAASLD late breaker poster. Let's now talk about the LIFT phase 2 Lonafarnib combo study design. This is 24 weeks, followed by 24 weeks of follow-up. Lambda, Lonafarnib, ritonavir boosting with a primary endpoint of greater than 2 log HBV RNA reduction at the end of treatment, histology at follow-up. This study was presented by Dr. Christopher Coe at FAASLD. Let's talk about the primary endpoint at week 24. 22 of 26 patients completed 24 weeks of treatment, with 17 of 22 achieving the primary endpoint of greater than 2 log decline in HBV RNA. 11 of 22, or 50%, were either below level of quantification or had undetectable HBV RNA. Adverse events were mostly mild and moderate and included GI-related side effects. Let's now talk about the follow-up, histology. But first, at that 48 weeks, 5 of 22, that's 23% of patients, maintained below level of quantification or undetectable HBV RNA. 20 patients underwent liver biopsy, and 11 of 20, 55%, demonstrated improvement in the HAI score, and 6 of 20, or 30%, achieved the secondary endpoint of a 2-point improvement, greater than 2-point improvement in HAI. These are encouraging results. Adverse events were typical for an interferon regimen using lambda interferon, relatively mild side effects, and GI from the Lonafarnib. We'd like to highlight here hyperbilirubinemia was seen in 19%, with 4 patients undergoing discontinuation. Exploration of why these patients develop hyperbilirubinemia, including the monotherapy study that I discussed earlier, is ongoing. I postulate there may be specific polymorphisms that result in this hyperbilirubinemia in certain ethnic or genetic subgroups. Integrated data for drug development includes the possibility of Lonafarnib monotherapy, of course ritonavir boosted, combination Lonafarnib plus lambda interferon, or possibly lambda interferon as monotherapy. We could get to this maintain or DVR, I'm going to put cure in quotations, of course, and even the possibility of maintenance therapies for this extremely serious disease. Let's now talk about that next step, which is viral packaging and release, and talk about nucleic acid polymers. I'm going to discuss here nucleic acid polymers, including Rep2139. These are oligonucleotides with a broad spectrum of in vitro antiviral activities that appear to block both uptake or entry in some models and release in others. Rep2139 developed to address tolerability issues and is modified so you can move from an intravenous to a subcutaneous dosing. Rep2139 calcium here plus pegylated interferon was presented in 2017 to suppress HBV RNA multiple logs during mono and combination therapy. The Rep301 long-term follow-up from the Rep301 study is discussed here, with 11 301 participants completing the therapy and having 3.5 years of follow-up. 7 of 11 had this functional cure, but we're going to call that a maintained virologic response with HBV RNA not detected and normal ALT. 3 of 7 had virologic control of hepatitis B, interestingly, and 4 of 7 had surface antigen loss with a functional cure. There was a transaminase flare that took place as S antigen levels fall below 1 international units per ml. Other exploratory endpoints included S antigen with a super-sensitive assay of less than 0.005. Pregenomic RNA was quantified, and correlated antigen was quantified. Takeaway points: Delta infection infects over 12 million people worldwide. It could be as high as 20 million. It's a more severe form of chronic viral hepatitis. Interferon offers at best a 20% maintained virologic response, although with therapy lasting sometimes 5 years, we reached a DVR that's higher than 20%, but at cost in terms of medicine and side effects. Will pegylated interferon be available next year? There are statements being made that this is being removed from the market. We now have 3 major targets of HBV in development: entry, replication, and packaging. But very importantly, many of these studies require an interferon partner. If pegylated interferon standard is removed, lambda interferon may even have more opportunities. I would expect a 40 to 60% viral clearance or 2-log reduction in delta RNA with these more advanced therapies as the results become available. I'd like to thank the organizers of virology education, this important meeting of Hepatitis B Cure, which of course is looking at Delta, and my wonderful partners who help provide this information, perform the research, of course the patients and their families, and our pharma partners.